We are live.
Okay, I'll start. Good evening, all. Welcome to the iFocus online lecture number 460. It is the 11th module of the refractive surgery program. Today's topic will be incisional refractive surgery, historical and current rules of incisional procedures for myopia correction. We have the pleasure of introducing our moderator for today, that is Dr. Akanksha Kaul. Ma'am is currently Associate Consultant in Center for Sight, Safdarjung. She's done her MBBS from Government Medical College, Bidar, Karnataka, DNB from Shankardeva Nethralaya, Guwahati. She's completed her fellowship in cornea and NTS segment in LVPI, Hyderabad, and then she was a faculty in LVP, Adilabad. She's also a section editor in cornea in Delhi Journal of Ophthalmology. She's a proud member of AIOS, DOS, and Cornea Society of India. She's presented in multiple national and international conferences and has also published articles in multiple national and international journals. We welcome you, ma'am. Over to you, ma'am.
Thank you, Shreya, for that kind introduction. I would like to begin by introducing our speaker for today. Shreya, if we can have the next slide.
Yes, ma'am.
So today we are going to be learning from Dr. Jayeeta Bose, ma'am. Ma'am is an alumni of AMU Aligarh. She's completed her fellowship in cornea and anterior segment from LV Prasad Eye Institute. Ma'am is a senior consultant with us at Center for Sight in Safdarjung Enclave. She has been a former adjunct faculty at LVPI, following which she has worked at various eye institutes like Lakshmi Eye Institute, Venu Eye Institute, IQ Hospital, Gurgaon. She was also awarded the President Abdul Hamid International Award by Bangladesh Community Ophthalmic Society. She is a member of DOS and AIOS. Ma'am has presented talks at national conferences. Ma'am has been an invited faculty for training surgeons and eye bank technicians at Nigeria and Dhaka on behalf of the International Federation of Eye and Tissue Banks. We look forward to learning from you today, ma'am. I would also like to introduce our chairperson today. So I welcome Dr. Neeraj Khungar sir, who is the chairperson of the session today. Sir has done his MBBS and MD from the reputed All India Institute of Medical Sciences, New Delhi. Currently, sir is heading the Center for Sight Eye Hospital at Ajmer. He's the Vice President of Rajasthan Ophthalmic Society. Sir has served as the Chairman Scientific Committee of Ajmer Ophthalmic Society and the Organizing Secretary for ROS Conference 2013 at Ajmer. Sir is one of the pioneers in phacoemulsification surgery in Rajasthan. He has participated as faculty in live surgeries in phaco as well as SICS workshops, has multiple presentations as faculty in various ROS conferences, scientific papers, surgical videos, and instruction courses in various national and international conferences. And Sir has received the gold medal for distinguished services in ophthalmology by the Governor of Tamil Nadu in IRSI Conference 2014. Welcomes you, sir, to the session today.
Thank you.
So, if we could start the presentation, ma'am.
Yeah, I think you have to stop sharing, Shreya.
Stop sharing. Please continue.
Yeah. Okay, is my slide visible?
Not yet, ma'am.
Not visible.
Yes, we can see your slides, ma'am, now.
Okay. Just a minute, let me move this thing a bit. Yeah, okay. So good evening, everybody. And today we will be discussing about incisional refractive surgeries, historical and current roles of incisional procedures for myopia correction. So just give me a second. I want to just yeah. So Now, those who cannot remember the past are condemned to repeat it. So let me start the presentation by this quotation by George Santayana. And the reason why, because although these refractive procedures, incisional surgeries are no longer done these days, but yet, we cannot afford to forget them, because these patients, they seem to come back again and again from the past to haunt us, be it in the form of some complication of these surgeries, or with some new presentation, like they may come with cataract, they may come with very severe astigmatism, which is not treated, not possible to treat with just glasses. So because of these reasons, we should know about these incisional surgeries, and we should learn from these surgeries what exactly was the thought process behind these surgeries, how these surgeries came into being, what was the history behind them, and then what can we learn from them. So basically, when we talk about the incisional refractive surgeries, there was radial keratotomy, astigmatic keratotomy, hexagonal and trapezoidal keratotomy. So all of them have been abandoned in their original form, except to some extent astigmatic keratotomy is used in the form of LRIs even today. So coming to the historical background, let us look at some of these people who were the pioneers of these surgeries. So Leander Jan Lans, he was a Dutch ophthalmologist who conducted the first systemic laboratory research on refractive surgery in rabbits. And basically, he defined the principles of radial keratotomy, and he was the first person to describe the coupling phenomena, which I will just come to shortly. And in 1885, Schoetz became the first ophthalmologist to treat astigmatism via incision. So we know Schoetz from his tonometer, but another thing which he is famous for is because of this incisions which he started using to treat astigmatism. And Faber, who was a Dutch ophthalmologist, was the first to perform anterior transverse keratotomy to improve his patients' vision and enable them to meet their occupational needs. So the next person who is important in this is Lan. And Lan's doctoral thesis basically talked about experimental studies on the treatment of astigmatism in non-perforating corneal incisions. And he published this description of trials which documented the effect of non-perforating corneal incisions in rabbits. And the few things which he's kind of demonstrated was that the deeper incisions had a more significant impact. The non-perforating corneal incisions, which were perpendicular to the limbus, caused peripheral bulging and central flattening. And keratotomy associated wound healing induced further flattening of the central cornea. The radial wounds flatten the central cornea and create a peripheral inclination in the median parallel to the wounds. So then this led to the principle known as the coupling phenomena. And in this coupling phenomena, basically, it says that when we make an incision in one meridian, the steepest portion, simultaneous flattening takes place in that meridian, and a steepening of the meridian which is perpendicular to it, 90 degrees away from it. And a coupling ratio is a metric which is used to quantify this effect, which represents the ratio of flattening at the site of the incision to the steepening at the perpendicular meridian. So this principle is used these days in the form of limbal relaxing incisions, which all of us are familiar with. And we found in limbal relaxing incisions also, the deeper cuts cause more flattening effect, and incisions which are closer to the center of the cornea cause more flattening. So as you can see in this picture of a patient who has undergone radial keratotomy, there is a peripheral bulging and a central flattening of the cornea. And along with that, there is also some more flattening which is caused by the keratotomy wounds. As they heal, they cause more flattening because the wounds scar. The next person who is important in the evolution of refractive incisional surgery is Sato. And unfortunately, I could not find a picture of Sato, but he is a Japanese ophthalmologist. And interestingly, he observed that in patients of keratoconus who develop acute hydrops and subsequently the descemet heals, there is a flattening of the cornea in these patients. And his idea, from drawing from these observations, he decided, or he kind of theorized that by creating breaks in the descemet's membrane, both through anterior and posterior approaches, we can make the cornea flatter and we can correct myopia. And initially, he did these experiments, initial surgeries on military pilots. and he designed a scalpel, which is a modified Laperson's scalpel, which has, this is what it looks like. And this scalpel could enter through the corneal limbus, and it can cut both the anterior and posterior part of the cornea. So what sounds like quite hazardous at this today, when we talk about it in 2024, was in the 1950s. This was it was lauded as a very effective way of safe method, as a novel, safe, and effective method of curing myopia. And in more than 95% of all cases of myopia in Japan, he has reported, which presented to his clinic, he was able to satisfactorily treat myopia by using this technique. But in 1953, he published his results in 32 eyes. And this was like, so many years back, 1950s, more than around 70 years back, all these surgeries were done. And people did not have a good understanding of the corneal anatomy and biomechanics at that point. So what happened was that 15 years after Sato's death, there was the first occurrence of corneal decompensation. And so this was one of the tragic consequences of his work. And in spite of this, he is one of the pioneers because of this surgery. And his results also kind of they were the similar results as theorized by Lanz. And he said that with greater depth, number, and length of the incisions, the effect will increase. Radial incisions placed in the meridian will flatten that meridian, and also the perpendicular meridian. Crossed incisions will produce pronounced scars, so they should be avoided. And his experiments were done on rabbit cornea. So the rabbit cornea's endothelium can regenerate, unlike the human corneas. So there was no incidence of endothelial decompensation in these rabbit corneas. Then the person who is, really associated with starting RK in a more systematic way was Fyodorov, and he applied some mathematical formulae to determine the most precise outcomes for each patient. So he also had a similar understanding of the subject, and he kind of decided that the optic zone should not be made less than 3 millimeters, because it can severely reduce the visual acuity and lead to other problems like significant glare, halos, and starburst. He established a coefficient to accommodate for variances in the surgical technique, and he also reported very exceptional results. And he said that in his patients, about 230 patients, all these patients with previous refractive errors of from -1 to -6 achieved a final refraction within 0.5 diopters of emetropia. But these fantastic results have never been replicated after Fyodorov. So Bose et al. Again, these were Americans, and we see now the marker which we are using for our uh, toric IOLs. The axis marker is actually named after Bose. So these Bose, Myers, and Cowden, they were the American doctors who published results in 303 eyes, and they found that the patients who underwent RK, 65% of these eyes achieved uncorrected distance visual acuity better, or equivalent to 20/40. So the refractive correction following RK was determined according to a few parameters like the age, the diameter of the optic zone, the number of incisions, and the depth of the incisions. And these variables could be titrated to the desired surgical result. And the patient's age also, later on, they realized that the age of the patient also impacted the surgical outcome. And the PERK studies regression analysis showed that there was an effect of 0.4 to 0.6 diopters higher regression per decade. And the variability of the refraction also increased when the optical zone decreased. So now we come to these were the principles of the incisional surgeries, and radial keratotomy is the one which was, I think maximum number of cases were performed of radial keratotomy, because this was used to correct myopia. So the patients also were more in number compared to hypermetropia and astigmatism. And in its current form, RK was developed in 1974 by Fyodorov. The incisions are made with a diamond knife, which you can titrate the depth up to which the incisions will be made. The center of the cornea is marked. An RK marker, I think all of us have seen. This RK marker was used to mark the cornea, and then a number of incisions were decided according to the nomogram. And using a diamond knife, these incisions were made. The original technique was making incisions from periphery to center, which was called the Russian technique. And the later technique was making incisions from the center to the periphery, which is the American technique. The Russian technique, because we were approaching the center from periphery, there were higher chances of causing some, scarring or some incision which is reaching up to the optical zone. So it can cause more visually debilitating side effects. Then another interesting type of keratotomy which was performed, of course, not many patients we get to see these days, is hexagonal keratotomy. It is done for hyperopia. It could be for naturally occurring hyperopia or hyperopia occurring after radial keratotomy. 6 incisions are made in the stroma in a hexagonal pattern, and this is also known to be associated with a high rate of complications, including keratectasia. And many of these patients need penetrating keratoplasty or lamellar keratoplasty because they have very poor vision and even contact lens intolerance. So this study, it shows a patient of hexagonal keratotomy who had severe ectasia. If you see the topography, you can see that the inferior cornea is very thin and highly ectatic. So this patient underwent lamellar keratoplasty, a DALK procedure, and you can see there is a regularization of the corneal topography, and the patient attained a good visual acuity. Another form of keratotomy, again quite rare, not really seen much these days, was trapezoidal keratotomy, originally introduced by Ruiz in 1980s. And here, as you can see in the diagram, there are multiple non-intersecting semi-radial and transverse incisions. The transverse incisions are in a step ladder pattern, and then there are semi-radial incisions, and they will be in the axis of the steep cornea. Again, complications could be perforations, shifting of the postoperative refractive axis, glare, wound separation, vascularization of the incisions, and poor visual quality postoperatively. Many of these patients will need contact lenses or corneal transplant. Astigmatic keratotomy is somewhat similar to the LRIs which we use even today, but the difference is that these keratotomies were made more towards the center of the cornea, not at the limbus, and they are known to correct up to 4 diopters of astigmatism, unlike LRIs which can correct maybe up to 2 diopters. And these are arc-shaped incisions. They can be made using a blade or a femtosecond laser. And some doctors have even reported that they can be done in the OPD. So this study basically compares astigmatic keratotomy, which can be full thickness or intrastromal. And they have done the study compared the effect of penetrating and intrastromal femtosecond assisted astigmatic keratotomy in eyes post keratoplasty as well as in naive eyes. And they found that in both these eyes, the reduction of astigmatism can take place. But as you see, the effect is highly variable. It can be 35%, it can be 85%. So we don't know which patient will have how much reduction of astigmatism. So in the current scenario, we cannot use this as a kind of a reliable method to reduce astigmatism because the results are so variable. But both these theoretically they can be used to reduce astigmatism in post PK eyes as well as in eyes without any surgery, naive eyes. And even they can be used for astigmatic correction at the time of cataract surgery. The complications are similar to other forms of incisional surgeries like glare, halos, perforation, irregular astigmatism. Now, very interesting and something which we should all know about is the wound healing after radial keratotomy. Initial studies which were done reported that there can be a high rate of loss of endothelial cells up to 15% just by the keratotomy itself, because the initial cut can even go up to the level of the endothelium, and microperforations can also take place. But the subsequent studies showed that the endothelial cell loss was not progressive, and it was an acute response to the inflammation, and this was kind of stable endothelial loss. So what happens when we cut the cornea is that the epithelium extends into these RK incisions, and it doesn't heal like a normal, epithelium of a eye, which has not had any cuts in it. And as they regenerate, these epithelial cells form cysts. And these cysts can lead to a variety of refractive effects like halos, glares, starburst, and irregular astigmatism. And the other thing which happens is that this kind of epithelial plug forms. All these epithelial cells, they start dropping into the wound and they form a plug. So this plug is like, you can see in the diagram, it's like a round ball of cells. And this plug can be almost 3 to 4 times as deep as the normal epithelial layer. And sometimes these cells migrate from the plug up to the surface, and some of them even die before reaching it. And they form breaches in the healthy epithelial layer. So because of these breaches, the epithelium is always susceptible to infective organisms entering it. And we know that post-RK or post-incisional keratotomy keratitis is common or even devastating complication, and it can be up to 0.7%. In the risk can be up to 0.7%. And the healing of the incisions is very slow and unpredictable. And it is said that they never completely heal. Even after many years of surgery, these incisions will not heal. And late ocular infections are quite common. And we should always be aware of this fact when we see these patients. Now, the very important PERK study, which is a prospective evaluation of radial keratotomy study, was the first study basically which assessed the safety, efficacy, and predictability of patients undergoing RK. And these about 793 eyes of 435 patients were assessed, and these patients had about 2 to 8 diopters of myopia. And all these patients had 8 incision RKs, and the diameter of the optical zone varied depending upon the spherical equivalent. The effect of age was not investigated. So they found that about 17% of patients had hypercorrection of more than 1 diopters after 5 years. And between 6 months and 10 years, 43% of the patients had a hyperopic deviation of more than 1 diopters, and there was an annual increase as well. So this progression which took place up to 10 years, and this progression kept on happening. It did not stabilize. The progression of hyperopia did not stabilize even after 10 years. And younger patients have a more greater tendency of progression, and they require multiple surgeries because the wound healing will be quite different in younger patients. And with better equipment like diamond blades and calibration, ultrasonic pachymeters will improve the predictability of this procedure. We know that this Fyodorov also discussed this, that by decreasing the diameter of the optical zone, we can considerably reduce the myopia. And the PERK study also showed that by reducing the optical zone diameter, we can additionally increase the refractive change. But there is a limit to which we can reduce the optical zone. Less than 3 millimeters of optical zone will not be very effective. They will cause a lot of glare in the patient, and they should be avoided. The number of incisions also, initially number of incisions used to be more, but over a period of time the incisions became less. And this study by Scatcher compared using 8 and 16 incisions, and they found that the correction was almost equivalent in both the number of incisions. There was not a significant difference. So these are the various nomograms which are used. There are other nomograms as well. And these nomograms are used. This is the first one is for the treatment of astigmatism proposed by Norden. And you can see that in this, there is an arc length is given and number of incisions is given. The second one is the hyperopic nomogram for treatment of hyperopia. Again, here the correction is in the periphery, the optical zone of 6 to around 5.5 to 6 millimeters, and cross-sectional length is made. And then there is the nomogram for myopia correction. So we see that as the myopia increases, maximum, I think up to 8 diopters has been given. The optical zone becomes lesser and lesser, and the number of incisions also increase. If you want to keep more incisions, then you can have a slightly bigger optical zone. If you want to have lesser number of incisions, you have to have a slightly smaller optical zone. So this is a trade-off which you can make. Then the direction, I think we've already discussed, centrifugal and centripetal, and some people have done two pass, like from limbus to the center and then from center to limbus. Then next is, since we have gone through the different types of incisional keratotomy and the study, let's come to the complications. So since this procedure is done manually, there can be a lot of inaccuracies, starting from the inaccurate visual axis marking. And this can, if the axis is marked off the visual axis, if the center of the cornea is not marked accurately, or patient moves his eye or whatever, then there can be totally different results from what is anticipated. And there can be these complications of irregular astigmatism, diplopia, glare, etc. And by chance, if the incisions are intersecting, say you have two opposite incisions intersecting, then there can be a lot of problems because it will come in the optic zone. And also these patients will have open wounds and they can have scarring and difficulty in healing. Microperforations are very common, and many times they're not even noticed because there is little bit of aqueous loss and it may be not noticed by the surgeon, and he may continue with the surgery. But microperforations are important because they can cause endothelial cell loss and they can lead to corneal decompensation in future. And by using pachymetry, we can see that the incidence of this perforations can be as much as 10%. Okay. And the perforations occur mostly in the inferotemporal cornea because this is the thinnest part of the cornea. Then sometimes incisions can extend into the limbus, which leads to vascularization of the incisions, and these patients become intolerant to contact lenses in the future, and also fibrovascular growth, etc., can take place, and which results in suboptimal visual outcome. Then late corneal decompensation, we have discussed, more common in the Sarto's posterior keratotomy, but even in anterior keratotomies and RKs, there can be loss of endothelial cells, significantly more in eyes who have microperforations, and also more in eyes which have smaller optic zones, because the length of the incisions is much more, and maybe at some point these incisions are very close to endothelium, and either because of actual endothelial touch or because of inflammatory effect, the endothelial cells are damaged. So all these things make RK unpredictable because every individual is different. There is a biological variability of eye from one person to another. Every surgeon is different, so the surgical technique cannot be exactly the same. And every incision cannot also be the same because the incisions which are made, depending on the surgeon maneuverability, the direction of the incisions, the right-handed and left-handedness of the surgeon, it is very difficult to replicate the same incision in every case. And of course, we don't know the biomechanical property of each cornea may be different. So these are the common side effects: post-operatively halo, starbursts, daily visual fluctuations, irregular astigmatism. All of them are common in these patients. And smaller optic zones are correlated with more higher order aberrations. Deeper incisions and increased number of incisions also had a more probability of halos and glare following surgery. Infectious keratitis is one of the dreaded late complications. It can occur up to many years. Most common organism is Staph aureus and Pseudomonas, which were identified for delayed onset. Now, a very interesting piece of trivia which I came across when I was making this presentation is the refractive changes at high altitude. Now, as we ascend and we go to very high altitudes, there is a hypoxic change. And because of this hypoxic change in the corneal cells, there is hypoxic corneal expansion in the area of the radial keratotomy incisions, because these incisions are already weak areas of the cornea. And because of very severe hypoxia which occurs at high altitude, the cornea will expand, and this causes a hyperopic shift. Now, this hyperopic shift, how much can it be? Now, just imagine from sea level to 12,000 feet, it is up to 1 diopters of hyperopia. Up to 17,000 feet, it can be up to 2 diopters of hyperopia. And Mount Everest is 29,000 feet. That means up to 4 diopters of hyperopia there could be a refractive change of this. So this famous mountaineer, Beck Weathers, he was a survivor of the 1996 Mount Everest disaster, in which this he was a pathologist and a mountaineer. He had gone on this expedition. So during this expedition, he had just undergone RK before he went on this expedition. So he experienced this high altitude hyperopic shift in his eye. So when they were on their way up to the summit, after this night, he came out in the morning and he was totally blind. He could not see because his refractive error had changed. And then because of a blizzard and snowstorm, etc., the entire group was abandoned, and they could not find their way back, especially because he was blinded. So later on, this person suffered frostbite. As you can see, his hands have been amputated and his nose is permanently damaged because of frostbite. And he wrote about his experiences in his biography. And this is a lesson which we learned, that what I mean, totally unexpected. Nobody anticipated this could ever happen, but the cornea can change at high altitudes as well. And another thing is diurnal fluctuation. So if your patients of RK, they say that we cannot see well at night because the curvature of the cornea keeps changing throughout the day. So imagine patient, he cannot even be happy with glasses because his number will change throughout the day as the day progresses, because of the variable wound healing and the epithelial plugs. The keratometry reading will change throughout the day, so which can lead to a very poor visual quality. This table summarizes all the various post-operative RK complications. Most common among these are progression, hyperopia, regression, and irregular astigmatism, and the dreaded complication of corneal melting and wound dehiscence. So to manage the refractive complication of irregular astigmatism, we can use these reverse curvature contact lenses, which have a slight flattening at the apex, and also oblate scleral contact lenses, which compensate for this shape of the cornea post RK. Then for traumatic rupture of the keratotomy scars, we know that the RK scars don't really heal, but the collagen fibers deposit a new extracellular matrix, and it results in a scar which is weaker than the natural cornea. So some of the uh, surgeons have proposed suturing of the cornea, and this people have done different ways of suturing of the cornea post RK. And this Green Lasso et al., he has described a continuous stromal suture in the form of like a circle. Though I'm not sure how he managed to put the suture, but anyway, this suture it's documented in literature that this suture was done, and basically it kind of cements the RK incisions together and prevents these RK incisions from gaping. There's another type of suture which was described by Donati et al. It is in these kind of arcuate incisions where there is a gaping of the wound. You can give the simple square suture in these radial or transverse incisions. Then for post-operative refractive errors, PRK has been done, and there are studies which have shown that PRK and even topo-guided PRK has led to significant improvement in both uncorrected as well as corrected distance visual acuity, and it has reduced the irregularity in the central cornea. But these patients, you must be careful because during the de-epithelialization, and preferably use alcohol or a transepithelial PRK to prevent these complications. Again, the results are unpredictable, so maybe multiple procedures may also be required, and definitely time will be required for the refraction to stabilize. Cataract surgery after RK, this is one thing which all of us must have faced at some point or the other. And what are the challenges which we face? The IOL power calculation formula is basically, people have suggested that use a different better to use Hage's Hoffer Q Holiday rather than the regression formulas, because it is difficult to determine the K readings, because there is alternate steep and flat areas of the cornea. So it is very difficult to determine the flat and steep axis, and for that we must correlate, or we must take multiple readings from different instruments, like we must do a Scheimpflug tomography, and then we must correlate these readings. And if we have any pre-RK keratometry value, we can use that. Or some people have also used this contact lens over refraction method. The corneal tomography or slit lamp scanning slit interferometry will evaluate both posterior as well as anterior part of the cornea. And the measurement in the 4 millimeter paracentral zone overestimates the corneal power and leads to postoperative hyperopia. So authors have suggested that we should aim for a myopic correction between minus 0.5 to minus 1.5 to avoid postoperative hyperopic surprises. And the rule is that for a 4-cut RK, add 1.5 to 1 diopter, and for 8-cut, add 1 to 1.5, and for 12-cut, at least add 2 diopters of IOL power. So if the formula which we are mostly using, if there's no refractive history available, is a true K or Haigis formula. And even after this formula, there can be refractive surprises. So this study showed that if we aim for plano or emetropia and 20 post RKIs, most of them will show a hyperopic shift up to 83%. Other intraoperative considerations is the incision size. If it's an 8 RK patient, then we can keep the size up to 3.2. And if it is 12 RK, then 2.2. But 16 RK is very tough because you might have to, your incision might, abut any of the RK cut. So there may be adhesions of the RK cut. In that case, you may have to use a scleral tunnel. Temporal incision is supposed to be better, and you can use a stabilizing suture. You can suture the wound near the incision site, and also you can suture the RK incision at that site, which will reduce the chances of suture dehiscence. And at the end of surgery, some surgeons have advocated that you check for leakage using a fluorescein strip. And Meduri et al., they have said that in 24 patients with 16 RK incisions, they found that these patients who had a wound dehiscence had superior incisions, and 20% had temporal incisions. Most of the patients who underwent who had wound dehiscence had superior incisions compared to the patients who had temporal incisions. And of course, scleral tunnel is also a good idea to avoid the intersecting incisions. Other considerations is you should keep the IOP low. A high IOP can lead to wound dehiscence. Intracameral air can be used again to form the AC and to manage the suture dehiscence. There will be a transient hyperopia for about 12 weeks because of the swelling and flattening of the cornea. There can be endothelial decompensation because these patients already have a compromised endothelium, and the cataract surgery may further increase this. And of course, there might be refractive surprises. So we must warn the patient that they might need some other procedure, or sometimes they might need a refractive, they might need a lens exchange. So this study, which has been done, it was a retrospective study of 100 eyes of patients with previous RK, and according to 52% of these eyes, who when they were the IOL formula was Haigis was used, they were within the range of 0.5 diopters of emetropia, and so Haigis is the preferred formula. And the most frequent complication which was reported in this study was the wound dehiscence. Some people have advocated the use of IOL pinhole implants, which basically have a pinhole effect. And this study, which was done by Sohn et al., has described good results with pinhole IOL implants in patients of RK. The current application of RK, as far as I know, could be only in the form of limbal relaxing incisions, which are partial thickness incisions. They are placed to control astigmatism. Along with cataract surgery, they can be done either manually or with femtosecond laser, and they can correct up to 2.5 diopters of astigmatism. Other indications of RK present, this one study which I found where they have done RK cuts in patients of keratoplasty who have got very high astigmatism. So they did 4 incision RK, and for visually disabling myopia post keratoplasty. And they have also done concomitant arcuate relaxing incisions at the graft-os interface. However, the reduction of the spherical equivalent was very variable, and it is not a predictable change, so we cannot use it regularly, and there's a high amount of variability, and because of the complex topographic changes which take place in corneal transplants, we cannot accurately predict whether RK will help in reducing astigmatism in these patients. Then another study has reported the use of light adjustable lenses. So with the 50 cut RK, which is quite rare, I think this patient had got 50, maybe he had repeated RKs for regression. So this 50 cut RK patient underwent light adjustable lens, but he achieved a final refraction of almost 20 by 20 and 20 by 25 in one eye and 20 by 20 in the other eye. So this is quite remarkable, I feel. And light adjustable lenses are, I think, a good option maybe in the future when they will be available more freely. But even in these lenses, it will take time, because to lock the refraction, it takes, I think, up to maybe 6 weeks or 12 weeks before the final refraction can be locked. And as a rule, we should remember that in post-RKIs, it will take 6 to 12 weeks for the edema to improve, refraction to stabilize. So don't give uh, refraction, don't give any glass prescription before 12 weeks. So I think at the end of this whole exercise, we have learned about RK. We've learned about the different types of incisional keratotomy and the historical importance and the follies which were committed and the lessons learned. The current role of RK in the form of the current role of incisional keratotomy is in the form of LRIs, which are a great tool to combat astigmatism. And what we should be aware of is post-RK, cataract surgery and IOL implantation, because these patients have now reached the age of 60 to 70. So now they are coming back to us with cataract. So we must be able to give them a good result post-cataract surgery. We are not the makers of history, but we are made by history. So I end with this, because there are many lessons to be learned from this whole exercise. And as doctors, as surgeons, we must know what were the mistakes made, and so that we never repeat them. At the same time, we should try to do our best for the patients who are still, bearing the side effects of these surgeries, and try to make their vision slightly better in whatever way we can. So thank you very much. And now any questions or comments?
Thank you, ma'am, for that very interesting talk, especially the history part, which we were not very well aware of. There was very interesting facts, and you're right when you say that the surgeries may seem very crude or barbaric now, but they led to the evolution of refractive surgery as we see it today. So if not for these surgeries, maybe we wouldn't be where we are today. And yes, in the current scenario, what is most important is that these patients come to our clinic for cataract surgeries, and then they pose a challenge in terms of the IOL calculation and the outcome. I would request Dr. Neeraj sir if he could give us some tips on his experience with cataract surgeries in post-RK patients, sir.
First of all, I like to really appreciate and congratulate Dr. Bose. She has covered the whole topic very nicely. Let me take you back to early 90s when we were struggling in practice, and we had started our practice, and we thought that we should start our practice with RK. So we were told that RK can make your career and RK can finish your career. This was the dictum in early 90s. And maybe in, I think, 89, 90, when I was doing my residency in RP Center, there was a child around 12 years of age who was slapped by his PT teacher in the school. And he had undergone RK with 32 incisions by one of the very famous RK surgeons of India. And the both corneas had ruptured. So this was like happening in those days. People were getting operated even at the age of 8 years, 10 years, and all the girls of marriageable age group in small villages and small towns, they were getting operated by this technique. So it was a magic technique at that time, but then later on, as Dr. Bose has covered, a lot of problems in that, and I think by 2004, 2006, it has almost been abandoned, and no one is doing it any longer. So now coming to the cataract part. The cataract part is very tricky. Now, what is happening is that why we are getting hyperopic results is that the usual keratometers or the auto K that we are taking the readings, it is measuring 3.14 or 2.6, 2.8 millimeters of the central cornea. Whereas what is happening is the central 1.4, 1.6 millimeter of cornea is much flatter in these RK patients. So especially if the cuts are more. So what we have to do is either we should have a very good optical biometer like IOL Master 700, which has telecentric like K values. It measures at 3 different zones and takes the value accordingly. And then it measures both anterior and posterior like the curvature of the cornea. And as rightly said, Haig's suite is better than Barrett suite. So if we put that patient is RK operated, the machine will use the Haig's suite as compared to Barrett suite used. Still, my personal choice, if I have a patient of more than 6 cuts, I increase the IOL power that I get by IOL Master 700 by 1 diopters. And if the cuts are more than 16, I increase the IOL power by 1.5 diopters. This is the power that I am getting by IOL Master 700. Initially, when we were doing immersion biometry, we were increasing it more as shown by Dr. Bose. I think Dr. Bose has shown it slightly less. What
Yes,
we
sir.
do is we even in 32 cuts, we were using almost up to 3 to 4 diopters more than the power that we were getting. So
Right.
in my place, Ajmer, again, there were RK was very famous, and one of the surgeons here was a very famous RK surgeon of India in this place also. But later on, they shifted to LASIK. With the advent of PRK, I think because RK was not giving predictable results, the whole scenario shifted to PRK, later to LASIK, SMILE, and all we have all gone through. I think all of you who are attending this session should realize that in 90s or 80s, when we people were into practice or when we were struggling to get into practice, we didn't have any access to internet. There was no social media. We could not get access to any of these studies that have been done. So we were just told that if you have a power of 4 diopters, give 8 incisions. What we were roughly doing is the number of incisions are double the myopia. And we were using a 3 to 4 millimeter, 3.4 to 5 to 4 millimeter central optical zone. And as described, centrifugal and centripetal approach. The centripetal approach is more controlled, gives you a better optical zone, but the results of centrifugal approach were better. This is what the literature says. So one is IOL power calculation in cataract patients that we have discussed. Second is incision making. Let me tell you, coming Monday, I have a case lined up with 32 incisions for which I have to do cataract. I am still having sleepless nights of where to make the incision. Because if I make a scleral incision, because I am making scleral incision in more than 8 incisions in all the patients. If we make a scleral incision and these RK incisions which are right up to limbus, I have to go slightly into the cornea. I am definitely going to rupture the incisions. And I can put a suture, but I know that there'll be leaky wound, there'll be surge, so there'll be a lot of problems. So one has to be mentally prepared for all these problems when you are doing phaco, especially if you are having more than 6 incisions. Up to 8 are still manageable, but more than that, it becomes really difficult.
Right, sir. So do you put a suture before the surgery at the time of starting surgery itself?
I have not done any 32 incision surgery before this Monday that I'll be doing, but I have not put any suture before. If I have a leaky wound, I stop there. I put viscoelastic inside the eye, then put a suture. Because I try to make a scleral incision, or I try, if their incisions are 6 or less, I try to go in between the incisions and I measure the internal wound. Basically, that internal wound, the corneal tunnel where it ends internally, that should be having quite a good gap between the two incisions. Because if you are very near to the incision, the amount of pressure that your phaco probe is putting, your needle is putting, that itself will create, and the hydration that is taking place, that can also cause the rupture of the incisions.
Sir, any experience of using toric IOLs in these patients?
Yeah. That is another very valid point. I am using toric IOL in many of RK patients, especially those patients who have a stable refraction, where the corneal topography doesn't show a very bad irregular corneal astigmatism. If the astigmatism is okay and it is stable over the period, I am using toric lenses. I am getting very good results in that.
Right, sir. And what if the patient desires trifocal or
No,
multifocal lens?
a big no to any of the premium Synergy, toric, trifocals, Synergy, multifocal, trifocals, nothing.
Right. EDOF, sir, EDOF, what is your take
I
on
think
EDOF lenses?
extended monofocals, even EDOF, as I have not used personally, so
Mhm.
I have no experience, because my dictum is not to use any of the premium IOLs, because these patients will be dissatisfied patients if they get any refractive error. As such, their surface is bad, they have a regular astigmatism, so many problems. So better to use a monofocal. But with the advent of extended monofocal lenses, I think Hoya Impress that I have been using. I am using a lot of J&J lenses, also INs, but Hoya Impress is giving much better results in these patients.
Okay. Any questions from Dr. Shreya or any from the audience? Is there any?
I think the take-home message from here is this also, that we know that giving a cut inside the cornea, giving a deep incision is going to definitely create problem, epithelial plugs and bad healing of the corneal stroma and all. So my personal preference is that we should, when we have got such good toric IOLs, we have got such good results with the toric IOLs. Now even 0.75 astigmatism, we are using toric IOLs. Why to go in for LRIs also? If you don't if you don't have access to femto. So femto incision, definitely it is good, but with diamond knife, we should not do that.
Right, sir. Mm-hmm.
Thank
Any
you so
more
much.
questions, Shreya?
Ma'am, I can see none in the chats as of now.
I think no one is interested in the past.
But sir, it was a great. It was it was very interesting to research about this because even I didn't
I
know
know.
about.
You have really, from 92 to 95, as I was wondering, I purchased a diamond knife also, which was costing around 65,000 at that time. And that was huge amount of money at that time, for a
Right.
beginner in practice. So, but I never did a single case, because
Oh, really? Okay.
my teacher, my mentor, Professor Dada, who was doing RK in RP Center, he told me, Beta, don't do it in practice. I am doing it here in RP Center, but otherwise you don't do in practice. So even after purchasing the diamond knife, I didn't do a single case.
Right, sir. So I think that was good advice which he gave you because so we have seen many patients of RK who have they have also got peripheral iridectomies done as for I mean what is the logic for that? Was it done for IOP
I'm
control?
not sure. I'm seeing a lot of patients, but I don't know why that was done. Maybe, and that was only one surgeon in India who was doing that. I will not name that. We all
Mhm.
know about him. But that surgeon was operating on 4 years child also, 6 years child also, which, you know,
So, what was the rationale behind it? Like, what was the thinking behind it?
rationale behind operating a young child.
No, sir, the peripheral iridectomies that were being done.
I don't know. Even I don't know.
The rationale was, I think, as a sort of IOP lowering thing because um, many patients were also on anti-glaucoma medication for a long time. They were kept on.
Maybe what I think of when you ask me this is that as the cornea was getting much flatter, the surgeon thought that there will be a narrow angle, shallow angle after that, because the cornea is getting a lot of flattening. So because of that, maybe he thought that let us do a peripheral iridectomy beforehand itself. Otherwise, the patient may not go into ACG.
Right, sir. Or maybe they wanted to decrease the pressure in such a way that it's well regulated and the cornea doesn't bulge out just in case it gets too flat.
But I think, sir, the positive thing is that most patients who underwent RK, if you ask them, they will say that yes, we were very happy. Initially, we had good vision. For a few years, we had good vision. We didn't need glasses. And then last 1 year, say, thoda problem ho raha hai. I say I think that is the most of the patients will not blame the RK surgeon, or they will be happy with the immediate post-operative results. So maybe for a few years, they got uh, kind of good quality of vision. They didn't have to wear glasses. So at the end of the day, they were not too unhappy. Of course, there was all these the complications were there, but a majority of the patients still enjoyed some amount of spectacle-free life for a few years.
Rightly said, because what the patients that the complications and other things we are talking about are on the patients which have come back to us.
Yes.
A lot of patients, a large database which have not come back to the ophthalmologist, and they are very happy. Like one of my classmates from AIMS, MBBS, who has done radiology, is practicing here only in Ajmer. His wife got RK done for -2 diopters. And still she is at the age of 58, she is 6/6, both eyes. So it is not that every patient is having this, but the percentage of complications is higher, the type of complication is very bad. So all those things matter. So any technique, any scientific technique which doesn't give us predictable results and a very low complication rate nowadays, with such a good advent of science and internet and all, we should not be practicing any. One more thing I'll say, that in the literature I also searched today, it says that there is a revisiting into RK for the treatment of keratoconus. So there is some research going on, as you said, that the Desmet's rupture. So similarly, on this basis, there is some research going on somewhere which says that they are revisiting the RK for the treatment of keratoconus. So I'm not sure what is going to happen. So we may be treating with RK again.
We don't know, sir. It must be in the very initial stages, a very advanced keratoconus. Maybe there'll be some flattening. Maybe, sir. I'm also not aware of this.
I
But
just I was just reading in the afternoon, but I thought I should know what's going on. So that time I came across this.
okay, sir.
So if there are any more comments or questions, otherwise we can end the session. I think it's close to 9.
Yeah, I think so.
So thank you, ma'am, for that wonderful talk. Thank you, Dr. Neeraj sir, for giving us these practical tips and for taking out time for this session. Thank you, Shreya, for coordinating the session. Lovely to have all of you today.
Thanks all. Thanks.
Thank you so
Thank
much.
you. Thank you, sir. So
Thank you,
nice of
sir.
you to be here. And you're one person who's actually, gone through that phase. So it was
Yes,
really
so
nice.
it was a very good learning, sir, from you.
Very insightful, sir. A very nice presentation, ma'am. Thank you so much.
Thank you so much, Akanksha and Shreya and Dr. Neeraj. Thank you very much. Uh, so have a good night, all of you, and we'll meet again. Thank you.